A very good morning to everybody. Dr. SRINIVASAN from Bangalore. Today we will be looking at a very interesting facial phenotype which is not very rare, which is something which we keep seeing quite often, but then a small subset of it is extremely rare, and that's what I want to show to you today. So we are all familiar with this mid-sagittal facial morphology, which we usually do when we do a TIFA scan. So in this mid-sagittal view, we have the frontal bone. You can see my arrow here. So we have the frontal bone, and then you have the nasal bone coming out from the frontal bone at a particular angle. So we have a scope to do what is called as a frontonasal angle measurement. So I've drawn this diagram so that for beginners it will be easy. So draw a line tangential to the frontal bone up to the frontonasal junction. Draw another line tangential to the nasal bone. Now the angle subtended is the frontonasal angle. Now do the same thing here. Draw a line tangential to the frontal bone up to the frontonasal junction. Then draw a line tangential to the nasal bone. Now this is the frontonasal angle. Now this angle should not be more than 145 degrees. So normally it's somewhere between 110 to 140, and that's the normal frontonasal angle, and that shows a normal morphology of the face, especially the midfacial morphology, which is assessed by this frontonasal angle. Now look at this mid-sagittal facial picture. Now you can see that the face is flat. You can see the skin of the forehead and the tip of the nose are almost in the same line. So this is a flat face. There's no need to do anything else, but we need to prove that it's a flat face. So draw the frontonasal angle again, and you can see the angle here is 151 degrees. So there is a significant increase in the frontonasal angle, more than 140 degrees, and this qualifies for a flat face or a mid-facial hypoplasia. So there is a mid-facial hypoplasia. There is a abnormal angulation of the nasal bone with the frontal bone, and this becomes an abnormal face. And this face and this phenotype is called as a binder's phenotype. The name comes from the phenomenon where if you put a bind across the face and tighten the bind, the nose will flatten and look like this. That's why it's called as a binder's phenotype. Now we do a 3D to get a good assessment of this face, and you can see that in the 3D the profile view shows a complete absence of the normal projection of the nasal bone outside, a depressed nasal bridge, and a flat face, and this is a 3D of a binder's face. It's another case showing a binder's face, and when you do a coronal view of the nostrils and lips, you will see that there is a flaring or broadening of the nose. there is a short columella, and you can see the frontal features show a flat, short and broad nose, and the lateral view shows a flat face. Another case of binders where whatever we learnt just now are demonstrated in a mid-sagittal view and in the 3D. So these are different cases of binders which usually one encounters on an average one a month or so. So now, since it is common, we need to know the associations and we need to know what to do when you have a binder's face. Now this is a antenatal binder's face. That's the abortus showing a flat face, and that's the X-ray of the abortus, again showing a flat face with a mid-facial hypoplasia. Sometimes patients accept the facial dysmorphism and rule out associated abnormalities and continue. So this is a binder's fetus which went into the 3rd trimester, where the 3D still confirms the abnormal phenotype and rules out other significant facial anomalies. So in a sagittal view, we have learnt how it looks, but in the axial view also you can see that the binders has a very flat nose which is almost in the same coronal plane of the cheeks, a broad nostril, and that qualifies for a nice mid-sagittal binders and an axial binders views of the face. That's a cine of the binders where the fetus takes a big yawn, and that's another cine of the binders where you can see the chewing type of movement of the face. It's very important to look at the maxilla, the mandible, to rule out clefts. Later in life, these binders can have hypoplastic frontal sinuses, hypoplastic paranasal sinuses, crowding of teeth, dental issues, oropharyngeal issues, etc. So we need to make sure that we are not going to miss some gross anomalies of the PNS area, the lips, the palate, the chin, etc. So if all those are ruled out, then it fits into a simple binders. That's the axial view showing a broad nose, widely spaced out nostrils, and that's the flat face in profile. Now what do we do next? The moment you see a binder's phenotype, we need to think of the associations, and the worst association is a skeletal abnormality called Chondrodysplasia punctata, or CDP. So how do you look for it? So when you do your TIFA at around 18 weeks, normally the foot does not have the visibility of a calcaneal and a talar ossification. All we will see is a few metatarsals and phalanges, and the heel region will be usually soft tissues without any bony appearance. So if at the 18 weeks or before 20 weeks one is able to show premature ossification of calcaneum or talus, then we suspect the association of a chondrodysplasia punctata. Of course, we need to prove that by an amniocentesis and an CDP gene assessment by a exome sequencing. So this is a abortus of a fetus which had premature ossifications, and you can see the X-ray of the abortus also showing premature ossification of the calcaneum and talus. But there's no proof yet, but the patients or the parents decided to terminate, and you can see the face showing typical binder's phenotype. So that's zoomed view of another fetus showing a premature ossification of the talus, and the same is seen in a sagittal view and an axial view of the foot and ankle. Now this is another fetus where there was a binder's face shown on 2D and on 3D with a premature ossification and a ventricular septal defect. This is another fetus where, apart from the typical binder's facial features and apart from the premature ossification of the talus, there is also a hypoplasia of the terminal phalanges as shown here on 3D and as shown here on 2D. So you can see that the terminal phalanges are significantly smaller. The 3D shows it much clearer, and this is a brachytelephalanx, which is an association of binders along with a premature ossification, telling that this is possibly a case of a CDP or Chondrodysplasia punctata along with the binders. Again, there was termination and there was no proof. Now I will show you the last case of binders with a proof of Chondrodysplasia punctata. So here we have again a fetus with an increased frontonasal angle, a midfacial hypoplasia, not so overt as the previous cases, a subtle flattening of the nose. You can see the nose is much inside as compared to the upper lip and lower lip. There is increase in the frontonasal angle. And now I will show you a cine of the humerus. Here you see classical premature ossification of the head of the humerus with classical stippling of the epiphysis. So that is a significant finding in this binder's phenotype fetus. Now you will see the femur, which also shows premature ossification of the upper epiphysis of the femur. Now you have a picture of the fingers showing classical hypoplasia of the terminal phalanges. Compare it with the middle phalanges and you can appreciate that it is very short. So here you have the middle phalanx, that's the terminal phalanx. You have the middle phalanx and that's the terminal phalanx. So classical brachytelephalanges, classical premature ossification with stippling of upper femoral epiphysis and upper humerus epiphysis. So stippled epiphysis, significant premature ossification of the epiphysis, short terminal phalanges led us to suspect CDP strongly. An amniocentesis was done and it shows ARSL gene located in exon 11 with a homozygous X-linked pattern suggesting the possibility of Chondrodysplasia punctata. The patient was advised not to continue, and that's the abortus. So this last case shows binder's phenotype with Chondrodysplasia punctata in the whole exome sequencing from an amniocentesis done in the mid-trimester. So what causes binders? Well, there are multiple causes. One is of obviously a trisomy in the 21, which is a Down syndrome. 2. Skeletal dysplasias like a brachytelephalangic chondrodysplasia punctata, which is a X-linked disorder, an ARIC variant, which is the case which we just saw. Stickler syndrome, Quetel syndrome, Warfarin embryopathy, maternal illness, SLE, benign familial variants, and also vitamin K deficiency are other postulated causes of binders. So I hope you learnt a lot about binders. It's a common occurrence. Learn to pick it up in the mid-sagittal view. Learn to measure the frontonasal angle. Learn to watch for premature ossifications, and if they are there, document stippling. And once you have this association, insist on an amniocentesis, show the variant and the gene abnormality, and counsel regarding termination. To continue or not, obviously, are the parents' choice. If you have liked this and if you want to learn more, please Google MEDIFLICK and look at my courses. From next month, that is June onwards, a fetal medicine master course will be started by me. There will be 12 meticulously crafted modules which will deal with early pregnancy, first trimester aneuploidy markers, second trimester aneuploidy markers, the respiratory system, the cardiovascular system, the genitourinary system, the gastrointestinal system, the musculoskeletal system, the spine, Doppler in the third trimester, and finally there will be an assessment, and whoever does this course will get a certificate in fetal medicine. Thank you very much for a patient hearing. Happy learning. Signing off from Bangalore, Dr. PRADEEP Srinivasan under MEDIFLICK. Thank you very much.